maybe we'll give it another minute and then we can get started. I know there was probably like 10 or 12 people this morning, and I think a few of them might have conflicts this afternoon, but I think some other people weren't able to attend or attended via Zoom and then are on tonight, just to give you some context.
Okay, great.
All right, we could probably get started. Thanks for the M1s for joining again. I know I saw some of you bright and early this morning. So hope that the first fracture conference was informative for you. We have Dr. Cott, who's one of the OSIG advisors here on the call. I'll let him kind of take it away with the debrief, but feel free to ask any questions throughout.
All right, great, Connor. Thank you. All right, so we did this summer for the summer immersion, and we got some good feedback about that to kind of break down the fracture conference, what some of you saw, or if you didn't come this morning, at least to learn maybe a little bit of the basics, a little bit of the terminology of what was happening, because that can be very overwhelming, especially if you haven't had too much exposure to orthopedic surgery. But basically, just to recap, is the residents get up and the intern goes first, followed by the chief resident, and then back down to the PGY2, and they present any fracture dislocation cases that they were involved with during the preceding week at either Robert Wood or St. Peter's or possibly one of the private attendings offices. And then they come back and present those cases to the faculty, where we ask questions just to make sure that they, understand what's happening, why it's happening, and then maybe go even a little further to ask, what would you do next? So based on just the pre and post images, we can talk about the whole case. So I want to jump into that. And I know everybody is very different with where they are and what they know. So, from what I've been told is sometimes it make it basic in the beginning and make sure we cover the bases, and then we can start to scale up, because a lot of this stuff just, reproduces itself a lot over time. So I picked out, several of these fractures. We can go over as many as you like. And, if it starts to get long, we could, table it for another day or find another way to do this. But we thought, periodically maybe to have these on Monday nights, if you are able to attend in the morning, that way you can, hear what this is all about and give you a chance to ask questions about why and what. And, sometimes I'll probably have to look them up as well. But this should get us going. And if you can put your camera on, I think that's great. You don't have to, whatever you're comfortable with. And, this is nice that it's not too many people, so it's pretty informal. And for those of you M1s that I don't know yet, I think that's awesome that you're on the call and, you're putting yourself out there and getting going. So this should be pretty fun. So M1s, have you guys had any anatomy MSK yet? Okay, so some of this terminology, and maybe you came from biology or physical therapy or something else, so you probably know more than I think you know. But in any event, for those who don't know, the X-ray is probably one of the orthopedist's best tools. So this is a lot of times our first diagnostic test that we do for patients to figure out what's going on. So we have our history where we talk to them, our physical exam where we put our hands on them, and then very often in orthopedics, the X-ray is the next thing. So before we get too far into it, we want to talk about what is an X-ray. And does anybody on the call have an idea of what an X-ray is, and just kind of the most basic terms? Connor, you want to get us going here and tell us your interpretation of what an X-ray is?
Yeah, that's a, a harder question than I thought was going to come. Um, but essentially, an X-ray is a way to, it's a radiograph that is able to differentiate between radiolucent and radio opaque materials. So it uses radiation to kind of see, um, like you can see the different like densities of material. So like the bone is more radiolucent, metal is going to be even more radiolucent versus like fat and muscle will be radio opaque. I'm sure someone else can give a better
Well,
explanation of
well, well,
that.
you're close. You're close, and I think the world of you. So I think you're mixing up radio opaque and radiolucent. But in any event, basically what we're doing is we're taking energy, and we have a machine that can generate this energy in a certain frequency or wavelength, and we direct it at the body. And then on the far side of the body, we have the capture. And depending on what happens to that energy through the body, it looks different on the film. So basically, what an X-ray is, it's high frequency, high energy radiation that goes into the body. And then, depending on what it does in the body, it's either going to pass through to the film or it's going to get scattered away. So things that are dense are going to either absorb the X-ray or make the X-ray scatter. Things that aren't, things that are more porous or things that are light are going to let those X-rays pass right through it. So if a film, if all the X-rays absorbed, the film will be white. Okay. If all the X-ray goes through it, if you shoot it into air, it will be black. So things that are light are going to be represented by black. Things that are really heavy or dense are going to be represented by white. Now, there are two things that is going to make something dense. It's going to be based on its atomic mass, which is going to be how heavy it is, and then also how close the atoms are packed together. So what type of atom you have and how it's configured. Metals have higher densities, they're closer together, and they also have atoms which have a higher atomic weight. So things like lead, things like steel, those things are going to be very dense and they're going to not let the X-ray pass, so they will be bright white. Things like air, things like soft tissue, they're going to be less dense, so they're going to be darker. Okay? If it's radiolucent, radio light, it lets things pass through it. If it's radio opaque, you can't see through it, so that's going to be something that's dense. So looking at this right here, anybody have an idea of what part of the body we're looking at? Steven, I saw you on first, and you're right on the top of my screen.
Yeah, that's the upper limb humerus.
Yeah, exactly. And what kind of gives that away to you? Like what stuff do you see in there?
Well, I can see the ribs and the
Yeah.
clavicle.
And what's behind what's, if you can see the rib bones, but what's between the rib bones? Is it light or dark?
Light.
Right. So I mean, so well, when I say it's light, I mean is it black or is it white?
It's more black. The
Right. So what is that representing?
in between the ribs, I'd
Yeah,
assume
yeah.
that's muscle.
Yeah, what's deep to your ribs?
The lungs,
Yeah, and what's in your lungs?
air.
Right. So air is going to let the X-ray beam pass right through it, where the bones are going to make it scatter. So the bones are going to be white, and then the air is going to be um, black. Now, what happens if you have a big mass in your chest? Let's say you have a incredible large lung cancer. What's that going to look like?
That's going to be more radio opaque.
Exactly. Right. So that's how we can sometimes pick up a lung tumor. And we can also figure out what side we're looking at because you have a big structure in the middle called the heart, which is not going to allow the X-ray to pass through it. So you're right. So we got the upper limb. And then in addition to the upper limb, can we tell if this person has a lot of soft tissue on their arm or are they super skinny? Can you give a guesstimate based on this radiograph? What do you think, Stephen?
it seems like they have a lot of soft tissue.
Yeah, exactly. So I would agree with you. So, I mean, you've seen people with skinny arms where, we say they're skin and bones, and basically the skin is right near here. But look, we got a lot of stuff that comes all the way out to here. I don't know if can you see my cursor?
Yes.
Okay, so this is the kind of the interface between the skin and the air. And then we got a large area here until we get down to the level of the bone. And then also all on the inside right here. So I would ask, when we put this person in a splint, do you think the splint works better if the person's skinny or if the patient's more heavy?
If they're skinny.
Right, because I mean that's just simple mechanics, right? You want to put the structural support as close as you can to the item that you're stabilizing. So if there's a lot of soft tissue in the middle of that, there's a lot more wiggle room for that bone. So I agree with you. Now, on the flip side, what would be a downside of, let's say somebody's really thin and you're going to put plaster of Paris, which gets hard, right on their skin? What could be a potential problem of that?
You could compress nerves and arteries more easily.
Yeah, that's very common. You could compress. I mean, hard to compress an artery to the point that it's a problem, but you could definitely cause a nerve problem, and also could cause a skin problem because now that skin is pinched between two hard solid objects, one being the bone and the other being the splint. So you have to be very careful about skin compromise, especially if that patient leaves and goes to a nursing home, comes back to your office 2 weeks later, you take the splint down and you're looking at the end of the bone. And that definitely has happened in the past. You have a closed fracture and then becomes an open fracture. So as we say that, and Danielle, you're right below him, so I'm going to ask you the difference between, and you probably heard this morning, the difference between a closed fracture and an open fracture. Any idea?
I wasn't there this morning, but
Okay.
maybe in terms of like a full break versus like a partial break in the bone.
That's a good thought. But that differentiation is more if you have communication with the outside environment. We call it open. So if there, let's say, was a big cut over the top of it, or there was a big, piece of skin removed and you're looking at the bone, then that's an open fracture. If the skin envelope is intact, it's a closed fracture. And sometimes it's a little hard to tell because the cut may be 3 inches below where the fracture is, and then you're like, oh, is it an open fracture or not? Because that sometimes changes management. So let's say you have that situation and you have a cut 3 centimeters below this injury, and you're not sure if it's open or not. Any idea what the blood would potentially look like in an open fracture versus if it was just a laceration? That's a tricky question. Megan, any idea?
It's an open fracture. Does that mean that it's like the blood would just be kind of like out
Yeah,
and
no, I mean, you
it,
would have bleeding both ways. If someone has a cut and the bone's not exposed, or if the bone is exposed, it could bleed either way. Anybody know what's in the middle of the bone when you guys did anatomy, when you opened it up? What's in there, Stephen?
It's the bone marrow.
Yeah. And what's one of the major components of bone marrow?
Uh, there are, I forget I think mesenchymal cells
There are
that feed
cells,
blood.
right? But one of the other big things is that there's a lot of fat inside there. Okay, so fat cells, okay, are going to look, you're going to be able to see the fat cells and fat. So oil and water don't mix, right? So the blood is just, if things are water soluble, you won't see them. But fat is not water soluble, so you'll see the fat droplets in the blood because it won't mix in. So that's one key sometimes, depending on the severity of the injury. If you see fat, there's a high likelihood that the bone marrow is coming out. So that's just a little trick that sometimes you can use to discern if it's open or not. And then we have other tricks as well, but it's always better to err on the side of caution. And what's the worry with an open fracture? So now you have a bone that's, the guy gets involved in a motorcycle accident and part of his tibia is sticking out when you come by. What do you think is a potential problem with that? Why would I be more worried about that than if the skin envelope is not broken? Alex, what do you think?
Maybe infection risk or
100%, right?
yeah.
I mean, the guy's got road rash on there, he's got gravel, he's got dirt. I mean, and then when it gets into that marrow, it's very hard to heal it. So it's important for us to give antibiotics right away and then to wash that out and get all that bad stuff out before the bacteria can set up shop. So that is why an open fracture is a relative emergency for us. All right, so we got our humerus fracture here, and oh, here's an easy one. Lauren, am I saying that right? You're with an S on the screen. I don't know if that's right or not.
Oh no, there should not be an S.
All right. Anyway, so Lauren, my question for you is, where was I going with this? With the humerus. Anyway, okay, this humerus fracture is we're going to figure out if it's open or closed. It's closed. And what else do you think we want to know about this patient in terms of their arm when we see them?
In terms of their arm,
Yeah. So you get called down there, you want to know about their arm. They told you had the arm was broken. So what's the difference? First of all, what's the difference between a break and a fracture?
is the break like all the way throughout the bone?
Nope, it's actually the same thing. So, and I always laugh when patients say, is it broken or if it's fractured? So fracture is just kind of the lingo that orthopedists and physicians use to talk about breaks. So break is a layman's term, fracture is the way we refer to it. So there's really no difference. So when you talk about fracture conference, if we were layman's, we would just talk about breaks. So this is a broken arm in layman's terms, or a fracture of the humerus. So this person was involved in a MCC, which I imagine is a motorcycle crash. And you think there was a lot of energy or a little energy that broke this arm?
A lot.
Yeah. So if there's a lot of energy enough to break the arm, what else could it do? What else lives in that area?
Different nerves.
Yeah, exactly. So you got to think of all the big things, right? You have arteries, you have nerves, and you have muscles, you have tendons, ligaments. So all those things are potentially vulnerable here. The good thing about the middle of the arm is there's not a lot of ligaments. It's pretty rare to have tendon damage unless you have a laceration. Those are pretty strong. An arterial injury, again, that would have to be super high energy, but things do happen. But you got to have an idea of what's happening with the nerves. Because if there's enough injury to break the bone, you can stretch the nerve enough that it's not working. So 3 major nerves in the arm, any idea?
The axillary, radial, and median.
Yeah, well, that's 3 of the 5. And then there are 2 more.
Musculocutaneous.
Musculocutaneous, exactly. And then what's the last one?
The ulnar.
Yeah, exactly. So any idea which nerve is the most vulnerable with a humerus fracture in the midshaft?
The radial nerve.
Yeah, exactly. Exactly. So we would want to make sure that the radial nerve is functioning. And I think the resident said the radial nerve was okay. So what are we going to do now? This person, you go down to see them and they're uncomfortable. So you're going to give them something for pain. And then we have to figure out what we're going to do. Are we going to do surgery on this person? Are we just going to send them out of the emergency room in a sling? Tell them good luck. I mean, what are our options to do here? So Kira, tell me some things you'd be thinking about right now.
Well, first, just making sure that he's like neurovascularly intact. Any like major swelling or any artery compromise might change your suggestion, but if you already got radiographs, you could see if closed reduction is your first line option, seeing if you can realign the bone.
Okay, so what's a reduction?
A reduction is essentially when you physically manipulate the fractured
I think we're losing
this
you
case
here.
extremity.
Yeah.
Close. Oh, can you hear me?
Yeah,
Oh,
yeah,
sorry,
yeah.
it's my
Yeah. So if something's perfect, like this person didn't have a fracture, we'd say it's anatomic. Okay.
Right.
And if it's not anatomic, it's off in some dimension or plane and it's not aligned. So in order to realign it, to try to get it as anatomic as possible, we're going to reduce it. Okay, so that's the word that we used to try to get it to the best prior position as possible. And so that the word that we use is reduction. It could be realignment, but reduction is the one that we use. And then you said we're going to do a closed reduction. So we say closed reduction, and the opposite of that is open reduction. So when we talked about closed versus open fractures, closed is we don't violate the skin. Open is we violate the skin. So, and then there's a couple little hybrids in there, but basically, if we're going to do a closed reduction, we're going to put our hands or a combination of hands on this person's arm in order to try to make this bone more anatomic. Does that make sense? So for some fractures, we can do that. Okay, some dislocations we can do that. Some places we just can't. There's just no way that you can get enough force in the right direction to put something back together. You need to then go to an open reduction. And we like to think about these things in a stepwise fashion to, follow the Hippocratic Oath and do no harm. So we start with the most simple things, the things that are the least invasive, the things that will cause low harm, and work our way up. So most of the time, if we can reliably do a closed reduction, we prefer that over an open reduction because we decrease our chance of risk. And then there's also more people involved and more expense and, other things going on. So in the emergency room, we can try a closed reduction to try to get this bone more aligned. Now, why would we want to do that even? What would be the benefit of a closed reduction? Aaron, I see you jumped on. What do you think?
I think a closed reduction would be better because you can put it in a splint. It would help with the bone healing, minimize the chances of like non-union, malunion. And if open reduction isn't necessary, you could reduce a lot of the complication risks involved in an open reduction.
Okay. So, yeah, I think you said it well. And even in more simplistic terms, if the bone is really crooked, do you think that will be comfortable for the patient?
No, there would probably be a lot of pain associated with it.
Right, because you're putting, tension, you're putting stretch on ligaments and muscles and tendons and nerves and things that aren't normally in that position. So, they're in a certain position for a reason. So we want to get that back to the most, comfortable position as quickly as we can. So that would be a reason for the closed reduction. It would minimize swelling. So if tissue's out of position or under stress, it's going to swell more. And that can kind of be this, cyclical thing that kind of, builds on itself and causes more problem. And you're right. If we don't realign it, it's probably going to heal in that position if it heals. And then there might be some deformity. The arm might not work correctly. And then the other thing being is whether you do a reduction or not, any type of splint will keep the swelling down, make the patient feel more comfortable, and protect it from further injury. So I would agree that if nothing else, this patient needs a splint. But if you can close reduce it and get it more anatomic, I think that's even better. It takes the pressure off all those other structures. So, Kira, you've decided to do a close reduction, and I think that's okay. After you do a closed reduction, you're going to put the patient in a splint. And in a perfect world, what would you want to splint? On
Well-
any long bone, what's kind of the mantra in terms of splinting? What
Like,
joints do you want to splint? Or do you not even want to put it on the joint? Do you want to just put 2 pieces of fiberglass on either side and wrap it with an ace bandage?
I think you'd want to splint. So like if you have a humerus fracture, you'd want to splint past the elbow. Just to avoid, so like you want to give the bone the best chance of healing, and to do that, you want to keep it in alignment. So for instance, if you have like a humerus fracture, certain muscles attach across the elbow joint. And by doing that, say if like you leave the elbow joint alone, not casted, and you have some sort of movement, like flexion or pronation, supination, you can mess with the alignment of the fracture that you just set.
Totally. So in a perfect world, if you can, if you have a long bone fracture, you want to splint the joint above and the joint below. That would be the most optimum way to control all the forces across the bone. However, it's very hard to immobilize the shoulder. You would have to go around the torso, and the problem with that is we get into compromising the lungs. So we typically can't immobilize the shoulder as well as we would like. But we would want that splint to be as long as possible. We wouldn't want to stop the splint just above the level of the fracture because there would be more motion there. That would again be mechanics. So you're going to splint around the elbow, as high up to the shoulder as you can. And then any idea what the name of that splint is? Well, the name we use for that is a coaptation splint. So you start it in the axilla, you come down around the elbow, and then you bring it up the lateral side of the arm. And some people stop at the level of the acromion. Some people even go up on top of the acromion, depending on where the fracture is. So it's a coaptation splint. It's like a sugar tong splint if you ever took a sugar cube out with a sugar tong, but the bend or the U part sits right underneath the elbow. So coaptation splint is like a sugar tong splint that's just reversed, and instead of going on the forearm, it goes up on the level of the humerus. And the alignment, you guys will learn this in terms of what you can accept here, but you can accept about 20 degrees in the plane of motion. You can accept about 20 degrees in the plane of motion, 30 degrees in varus valgus, which depends on if the bone is coming toward the midline or away from the midline. So this is varus deformity, and this is probably on the high amount of acceptable before you start to have arm problems. So you're going to realign it. And when you go in there, basically you're going to take the elbow, you're going to move it away from the body. Your other hand's going to be right over the fracture site, and you're going to push it over and see. Sometimes on these, you can actually feel it interdigitate and get a better reduction. So let's hear, I don't know if this will work.
Motorcycle collision transferred to our institution for this left humeral shaft fracture. Closed injuries, nerve intact, radial nerve was intact. He was reportedly initially splinted at the outside hospital, but we did not see any evidence of that. So he was closed reduce, placed a coaptation splint here. He will follow up for fracture functional bracing.
Do you guys hear that? So I think a lot of that terminology that probably went right over everyone's head this morning. I think we defined a lot of those terms, and then Ben just had that roll off his tongue in about 15 seconds because this is the stuff we commonly use. And you can see now on the left screen, the alignment's pretty good. On the right side, it's a little hard. And the reason being is this is a lateral image, and you're shooting through a lot of stuff. So when we talked about radio opaque or being really white, you're shooting through plaster, you're shooting through arm, you're shooting through the vertebral bodies. So it's really hard to kind of pick out what's humerus and what's everything else. So this one is a little bit harder to see on. But this one, where you start you describe the X-ray anterior to posterior being the front of your body, posterior being the back, you have an anterior posterior view that shoots right through it, and the alignment there looks much better. And is this a simple fracture or a comminuted fracture? I'll go back to you, Stephen. What do you think?
I'm not sure, but I'd guess simple.
So there's a little bit of comminution. So simple fracture, there'd be just two pieces. It'd be like if we took a knife and cut right through it. Instead, you have this little piece over right here. That's a separate piece. That's a third piece. Piece 1, piece 2, piece 3. So if there are more than two pieces, it's comminuted. And typically, the more comminuted a fracture is, the more challenging it is because you have multiple pieces that you have to deal with instead of just two. So there's a little bit of comminution here. And then when we talk about these fractures, is this more of a transverse fracture, a vertical fracture, or an oblique fracture? Deanna, what do you think?
Transverse.
Yeah, so it's not 100% transverse, but it's probably more transverse than anything else. And this can make a difference in terms of how we treat these. So, and then the one that we didn't talk about is a spiral. That's if you were able to grab the bottom of the forearm and twist it, because that's another plane that it can move in. That would be a spiral fracture. So oblique, spiral, transverse, vertical. This is more of a transverse fracture. The worry with this one sometimes is there's very little surface area for it to heal. So you're only going to be able to kind of join in these two areas right here, which makes it a little bit longer sometimes to heal. In case if it was a more oblique fracture, there'd be a larger surface area of exposed marrow there. All right, so anybody have questions about this first humerus fracture? We kind of went into a little case on the background of this, but before we move on, anything burning about humerus fracture you want to talk about or terminology?
I have,
Go ahead. Oh, go ahead.
I have a quick question about this, it not being a simple fracture. So that little third piece that's off,
Yeah.
the bone fully heals. What happens to that? Will there just be a protrusion from the bone there?
Yeah, there may be. Or, it's a possibility that this, let's say there's a tendon attached to this piece right here. And then when we see this patient in a week, this piece is even further out. So there's a chance that this piece of bone doesn't incorporate in the fracture, or there's a chance that the bone bridges and you have a little protrusion. Now, when this heals, it's going to heal with a lot of callus. The way I think about bone healing, it's like someone comes in with a dump truck and then dumps all this material on there. And that is at first soft callus, which is hematoma, and then it slowly calcifies. But the body's not good at knowing exactly where it needs to go. So it just dumps extra in. And then over time, it remodels and kind of takes away the protuberance, if you will. So this whole thing will form like a big ball of bone right here. So this is probably close enough where that will be incorporated in it. But there are certain times in certain places where you're absolutely right, where a free fragment can become a problem later on, especially if it's right by the level of the skin. And sometimes you have to go in and take it out, or it can be a problem because a lot of you need this to heal bone to bone in some cases. So this one's close and probably okay. But if a big piece of bone is too far away, that might prompt you that this is not acceptable.
Okay, thank you.
I heard somebody else saying something. They may have dropped off here.
Yeah, I was just curious. I've heard the terms like hairline or green stick fracture. I was just curious what those meant in terms of a break, like if they look different.
Yeah. So a hairline fracture is a break. And if you want to talk about simple fracture, or let's say the bone is cracked, but it's not out of place at all, it's still anatomic, except for you see this tiny little line through it. It's broken, but it hasn't moved at all. In my mind, that's where hairline fracture would come about. because you just see this, fine little line of the fracture on the X-ray, almost not even apparent, and there's no displacement. So that's hairline, and then green stick fracture. So bone is living tissue. So it can either break, like you're breaking a stick, or it can bend. And a certain subgroup of people, their bones start to bend before they break. Any idea what group I'm talking about?
Children, maybe?
Exactly. So sometimes children can bend, and there's enough force where it deforms, or we call it plastic deformation, where it bends, and then if there's additional force, then it breaks. So typically we see green stick fractures in children. And a lot of times we see it in the forearm where one bone will break, but the other bone will bend. So one will have a complete fracture and the other will have a green stick fracture. And sometimes those can be even trickier than full breaks, because with a full break, we can align it and hold it. But a green stick, it's like, you can think of the parallel like out in nature. When something bends, you pull it back, but the force on it, it seems like it wants to bend back, and then you can lose your alignment. So sometimes we take a green stick fracture and we actually just finish it, complete it, make it a break, so then we can set it and be able to hold it where we need to.
Thank you. That was super helpful.
Deanna, did you want to say something? Did I cut you off? Okay. All right. So let's go to 651. Okay. All right. So David, are you around? Do you want to take a gamble at this one? All right. Megan, what are you thinking here? What are we looking at? It's hard because we don't have the ribs to give us kind of any place to centralize to know what we're looking at. So we just have these bones in space.
Well, the X-ray says we're looking at the elbow, but if you can identify this, you see like the radius bone and the humerus bone.
Got it. And what are you thinking when you first see this?
It looks like displaced where the humerus.
Something doesn't look right, right?
Yeah.
So you first look at that and say, well, that doesn't look like a normal elbow. In a perfect, you asked you put an order in the computer for 2 views of the elbow. You wanted an AP and a lateral view. And that's what we call orthogonal views. And when we do any imaging, we want to get orthogonal views because something may look perfect on one view, but be completely off on the other. So 2 views of the elbow, orthogonal views. Does this look like a normal elbow to you? And if not, why not?
I think maybe not. From where I'm looking, kind of, I think I forgot what it's called, but I think it might be like the trochanter.
The trochlea?
The trochlea, sorry, of
Yeah.
where the radius, no, the ulnar is.
All right, so let's go back. So
aligns with the
which
humerus.
which bone is this right here?
The humerus.
Right. So what we were looking at before, if we just went a little distal, if you go up to the shoulder, that's proximal. If you go down to the hand, that's distal. So as we go distal, the fracture that from the previous case was above us. Now we're getting down to the elbow joint. Elbow joint is where 2 bones come together, and this is the humerus. He said there was maybe a little fracture right here. So Danielle, this is a hairline fracture probably here. That's a little bit of a soft call, but that's not this patient's main problem. Does this joint look like it's lined up? In a perfect world, there should be a little black between the bones. And maybe I can just jump ahead. I'll show you somewhere else. Okay, here, this is perfect. I just kind of landed on this. But you see there's a little bit of darker color right here between the bones. What is that? What lives between the bones?
Ligaments.
On the outside of the bones, but when the bones articulate, any idea?
Joint space,
Joint space. So what's in the joint space?
cartilage,
Right. And what kind of density is cartilage? Is it going to be
water
denser than
dense,
bone or lighter than bone?
lighter.
Why?
It's water dense.
Okay,
So
but what element is it missing that bone has? What's the number one element in bone? When your mom told you to drink your milk.
oh,
What was it?
calcium.
Right, right. So calcium is heavier, right? It's element number 20, whereas cartilage doesn't have any, and it's just made up of carbon, hydrogen, oxygen. All of those are very light. So cartilage is like soft tissue. It's going to have that same density. All right. So yeah, normally you don't have air between the bones. You have cartilage, a couple millimeters of cartilage, unless you lose your cartilage. And then what do you have? Kara, if you lost all your cartilage in your knee, what would you have?
Osteoarthritis.
Right. You'd be bone against bone. So we need that cartilage so we can move. You lose that cartilage, you're in a lot of trouble. And we have a couple millimeters of cartilage on either side of the bone, and then those two pieces of cartilage touch each other. However, when we went back to our other case, so remember this X-ray, and now go back to our other case at 651. That doesn't look right to me. I want to see 3 millimeters of cartilage. I don't see anything. I see an overlap, right? So besides this little thing, which may be a fracture, any idea what the major problem is here? Lauren, what do you think?
Dislocation.
Right, right. So what's a dislocation?
When it goes out of like the joint socket.
Okay, when a joint is not aligned. Okay, when a bone is broken or cracked, that's a fracture. But when a joint where two bones come together are no longer aligned, if it's partially out, anybody know what that term is? Anybody athlete that had this to their hip or to their shoulder? Subluxation. So if it's partially out or goes out and comes back in, it subluxates. But if it's totally out, it dislocates. So you're right, this is a dislocation. So you can see it right here. The humerus bone should be sitting right in here, and it's not. Now, the way we describe this is we describe it based on, we say the proximal fragment is in the right position, and the distal fragment has moved relative to the proximal fragment. So is this an anterior dislocation or a posterior dislocation? What do you think, Arian?
It's posterior.
Right. So what do you want to do? You want to send them home, have them come see me on Thursday when you're coming down?
You would probably close reduce it and put it in a splint.
Right. Exactly. Why would you do that?
So it can, so you can immobilize it, put it back in the right place, get the cartilage, time to recover, and I guess prevent any future injuries to it, to a joint.
Right. Right. So you're on call and you're busy and they call you and you kind of blow it off because you're tired. You say, I'll come down and check it in the morning. What could potentially happen in the 6 or 8 hours if this is just sitting out?
It could start to swell and maybe even ossify.
Not going to ossify,
Not this quickly.
but as it swells, what's around there that's trouble?
Well, you got brachial artery and some of the neurovascular, the median nerve.
Right. Mainly the neurovascular structures, and most particularly the nerves. They don't like that. You got bones sitting on nerves. You got the whole thing swollen. You're going to come up, and the guy's going to have a numb hand. So dislocations are another relative emergency. You don't want to leave these sitting out because the swelling happens really fast here. So in order to dislocate a joint, what has to fail? What got injured here in order to allow this to dislocate? Did the bone break? Not really. Maybe a little chip, but that wasn't the main problem. What holds joints in place? What do you think, Alex?
Maybe tendons or ligaments.
I like the second one. So ligaments go bone to bone, tendons go muscle to bone. So sometimes the tendons can be some secondary stabilizers, but oftentimes the ligaments are the primary stabilizers. So this person tore or stretched some ligaments, probably tore in this case, enough so that the two bones were able to move out of position and dislocate. So you're going to do a closed reduction. You think that would hurt, Danielle? If this was your elbow?
I think it would hurt, but it would feel better once it was placed back.
I think you're 100% right. So is this patient in pain right now? You're going to see him?
Yes.
They're hurting, right? They just came off, they were playing beach volleyball, and they're lying on the ground. If you ever saw something like this person's uncomfortable. You know, the bones, the ligaments, nothing wants to be in that position. So what are you going to do before you close reduce this? You going to bring your bullet, Danielle, for them to bite on? Or are you just going to tell them to hold on?
I don't know. Can you give them pain meds before? I don't know.
Yeah, I would.
Okay.
I mean, they're hurting, right? What else could you do? What do you think, Stephen? Can we make this any more comfortable for this person?
Maybe try to move it into a position that puts less strain or stress on that area.
Well, you could, but I mean, if there was something major, but you're going to realign this, you're going to do a reduction maneuver. So maybe you can move it a little bit, but they're uncomfortable. So kind of along those lines of pain medicine, what's the next level up than that? And there's different degrees of pain medicine, right? I mean, you could give someone Tylenol or you could give them morphine. But if they're in there just writhing in the emergency room, what's the next thing we could do?
An anesthetic of some
Yes, exactly. So that's an option you have. Are you going to call anesthesia down, or are you going to talk to the emergency doctor? And this might be a little harder. Is there anything we could do in the region of the elbow to help us out? That would help a little bit with the analgesia.
Can you do like a nerve block or like a local?
Yeah, you could do a nerve block. A nerve block's a little hard here, but you could do a local block. So you could put some lidocaine in the joint. And then we'll see that when we do fractures, we can put the lidocaine right in the fracture, and that's called a hematoma block. So we take the blood out and we put the anesthetic in there, and that can help with the pain. So that is certainly an option here to put some lidocaine in the elbow to help with the reduction. But I think that, there's another benefit of anesthesia. It's a little bit of a pain and you need somebody else to help you. But not only does anesthesia make them not feel pain, the anesthetic drugs can also relax them. And the relaxation may be helpful depending on how big this person is. This guy's a bodybuilder and all his muscles are really tight. You might not have the strength in order to combat that and pull this back in place. So sometimes having anesthesia that can either give some medicine just to relax them, or we even have depolarizing agents we can do to make sure that their muscles don't move. So we say that sometimes when we're doing a patient that's really big with a hip, that's out of place. We say, are they sedated? are they paralyzed, which means we use something to make sure that their muscles don't move to make it a little easier to pull it back in place. So you gave the patient morphine, you put some anesthetic in the joint, they're as calm as they can be. You made sure that their family member sat down, because nothing worse than having their family member pass out as you're trying to do this. And then what's your maneuver in order to put this back in place? They're all ready and they're watching you. So Connor, what are you going to do to this arm?
You want to like pull it distally to help lengthen, like you want to, I don't know, you want to like use gravity to help like pop it back into place.
You might be able to use gravity, but basically if it's posterior, you have to take that distal piece or the forearm and move it anterior. So you have to put enough force on that. And then there's a structure right here, coronoid. So if you just tried to yank it anterior, you'd do damage to the coronoid or you'd have a block. So you have to pull it down and around and pop it up right here. And then once you pull it back in place, and there are a couple techniques for how to do that, either with the patient lying down on their back or on their belly, and then we can talk about that. But you've got the elbow back in place, then what's the next thing that you want to do? And I think, Aaron, you said this.
Check neurovascular function to make sure when you
Well, right now they're
yeah,
under morphine. They got something else, so
okay.
they can't really tell you. But what would I want to know when you called me, because you're on call with me and you say, all right, Dr. Cott, I have this kid with an elbow and I sedated him and I got it in place. What do you think I would want to know?
This is before we do the reduction.
No, you just did the reduction. You
Oh.
got it back in place.
Take an X-ray, make sure
Even before you take an X-ray. What would I want to know? Like, I want to know how serious this is, right? Like,
yeah. So I mean, you could check for swelling, but
yeah,
that would
well,
be
it's going to be
solid.
a little swollen.
Yeah.
But more specifically with the reduction, is it stable or is it unstable? Right? If this
Yeah.
thing is stable and you take it through a range of motion and it's not moving, we might be done. If you try to take it through a range of motion and the thing pops right back out, we got a problem. We should probably see this guy in a few days, because if we don't, he might even come out when he's in your splint. And now we have a dislocated elbow that's been in the outside world with a big problem. So it would be nice to know, is this thing stable or not? And you're going to just test that with a little bit of range of motion to see how unstable it is. So we find out it's stable, you're happy, and now before you take your x-ray, or sometimes you will get an x-ray first if you really want to see the bones, but let's say you have to take the patient across the hall to an x-ray. What do you want to do after your reduction? You mentioned it.
Check for a neurovascular and
Yep, you're going to do that. But how are you going to protect this arm?
splint.
Yes, yes. So you're going to splint this patient. Do you think you want to put the elbow straight or elbow bent?
Probably flexed.
Yeah. So extended is straight, flexed is bent. Do you want it flexed all the way up, 140 degrees?
No, probably around 90 degrees.
Why?
Because then the joint is perpendicular and gravity wouldn't be pulling down on the joint.
That's true, but also that seems to be the position where there's the least amount of tension on the structures at 90 degrees. And it's also comfortable to leave in a sling. So if it's all the way bent, you put tension on your posterior structures. If it's all the way straight, you put tension on your anterior structures. So right at 90 degrees is probably perfect. And the way we do that is with a posterior splint. And then anybody that's been in construction, you want to support that, because if you have a posterior splint that's very long, you're going to have basically a long fulcrum right at that pivot point on the back of the elbow. So if we put a sidebar on that, that's going to make it a lot stronger.
Injury to his left upper extremity after he was trying to stop the car from backing into him. the left elbow dislocation and small avulsion fracture on the lateral condyle, epicondyle. He was neurovascularly intact, no other injuries, closed reduced, splinted. He was given follow-up. The hurdle fracture on the lateral epicondyle seemed like it could have been like a little avulsion off the LCL, but it tacked down pretty well after the closed reduction. He had also good varus and valgus stability after the reduction. So the plan for now is just close follow-up and reassess stability and range of motion after.
All right, so I think we hit a lot of those things, and then you can use fiberglass, you can use plaster of Paris. Plaster of Paris, you can see that running down the back right here. That's your posterior splint, and then this is the sidebar right across here to make that stronger. All right, so elbow dislocation, closed reduction, splinting can be followed up in the office. Connor, should we call it or do one more? We're almost 9 o'clock.
Yeah, I think we can call it. I know Dr. Jason Yang's also coming later this week. He's going to come to Piscataway and do a lecture as well. So we'll have that, and then we'll have the fracture series in October. So I think we can call it for now, and then do this again sometime as they get more anatomy through their M1 curriculum.
Perfect. So this was just a quick introduction to what we do as orthopedic surgeons. The first part's learning the terminology, and once you get that down, a lot of this is transferable to different places in the body. But hopefully I taught you at least a couple of the common principles of what we're doing. So you feel Connor, you just give them my email or cell phone if anybody has any questions. Be glad to answer them. If you guys think this is valuable, I can come on in another month or so and be glad to do this again. All right. Any